Thank you. So this box was found in the Derbyshire Royal Infirmary in a dusty broom cupboard. What relevance has it got to the British Journal of Surgery, and what relevance has it got to modern vascular practice? Well, I believe it's got some significant relevance. This talk is all about the old and the new. How can we introduce new technology safely, and what can we learn from history? As some of you may well be aware, the ideal recommendations were recently published in The Lancet, and they outlined how one might introduce new technology safely and in a timely fashion with the most surgical and scientific rigor. And essentially this can be applied to a number of vascular interventions, and one particularly close to my heart is the endovascular treatment of ruptured aneurysms. And essentially it outlines the innovation stage, developmental stage, exploration and assessment in properly conducted randomized trials and long-term follow-up. So in terms of innovation, if one looks at aneurysm repair, and particularly of coiling of aneurysms, it was first described at the Middlesex Hospital by Moore with some success. Later adaptations were made to try to improve the technique with the use of electric current to induce thrombosis and therefore reduce the stress on the wall of the aneurysm. Branshoff actually managed to treat a thoracic aneurysm successfully in 1886 with these modifications. Colt adapted and developed the procedure further, because at the time the main problem was to introduce sufficient wire to induce successful thrombosis. And he introduced a wiring umbrella to really pack the wire into the aneurysm. Until that stage, it was very difficult to do so. But I will draw your attention to something that is really part of modern day vascular practice at the moment, and that is a coiling Amplatzer plug, which is often used in hemorrhage, particularly for occlusion of the internal iliac artery. Very similar device indeed. So clearly we have learned something from history. At the time, there were clearly some skeptics, and the main problem, of course, was the fact that a lot of patients did very badly from the procedure. They went on and actually ruptured their aneurysm, they got sepsis, and they died from bleeding. And Blakemore produced this editorial in Surgery, which is very similar to the article by Murray and Collin, which was much vaunted in the vascular literature at a time when the first generation of endovascular aneurysm repair devices were failing in the long term. So there's a great deal of skepticism. Altman and Voorhees were quite forward-thinking. They actually reported a case of a patient with syphilis treated successfully with wiring of the aneurysm, which unusually the patient survived for 38 years. But at that time, they performed what we might term as a review of the literature rather than a systematic review of the literature, and they were able to find 100 patients. They found, in a way that we have adopted today, they looked much more at patient-reported outcomes. They found that the vast majority of patients had some sort of symptomatic relief, but they were quite concerned about the poor long-term data, and the vast majority of studies reported data of less than 1 year's survival. So the question is, why then in 1963, a year which I'm sure all of you will remember because Blythe Spartans won the Northumberland Senior Cup, essentially, do we have a leading article in The Lancet along the new innovations line of aneurysm wiring machine by Professor Peacock, who was subsequently president of the Vascular Society. He was able to draw on some quite considerable assistance at the Bristol Royal Infirmary by a Mr. A.E. Christmas, who was to develop his aneurysm wiring machine. And the problem, of course, as Peacock saw it, was that there's a problem of issue of actually being able to deploy a vast amount of wire into the aneurysm sac. He saw that Colt had great difficulties actually inducing thrombosis of the sac. So Mr. Christmas was able to develop this device very nicely for him. And if some of you are quite interested in this, then you can still purchase this from Messrs. Thackeray from Leeds. But essentially, he performed a long left paramedian laparotomy and introduced his wiring machine at 4 or 5 levels, and at each level introduced up to 100 feet of wire until he successfully thrombosed the aneurysm. And he was very careful that his assistant would feel the femoral pulses to make sure they actually hadn't interrupted flow to the lower half of the body. But essentially, he treated successfully 14 patients. At least he thought he treated them successfully. In the report of British Journal of Surgery in 1968, he'd actually treated 10 successfully. The 4 patients he treated with ruptured aneurysms all continued to bleed and expired. Patients were admitted for a total of 14 days in total, and 2 patients had complications. So why is it that we haven't adopted this sort of technique across vascular specialties? Because clearly we are using similar techniques to induce thrombosis of pseudoaneurysms, particularly the femoral artery after cardiac interventions. We are using them in intracranial aneurysms successfully, and difficult to access peripheral aneurysms. In the era of first-generation aortic stent grafts, we learned that thrombosis per se of the aneurysm sac was not necessarily successful. A large number of the first-generation devices didn't have proximal attachment zones, and often the device would slip into the aneurysm sac, causing immediate thrombosis. A significant number of these thrombosed aneurysms went on to rupture. We actually don't know a great deal about wall stress and pressure within aneurysms, although that is improving with new techniques such as finite element analysis. Clearly, thrombus does have some ability to reduce wall stress, and some work performed by ourselves and by Mark Fillinger's group has shown that these various hotspots and high areas of or high wall stress predicts a group of patients who go on to expand their aneurysm more rapidly than patients with low wall stress. But clearly, thrombus has other potential problems in that it's often a milieu for aneurysmal degradation of the wall. Similarly, we don't know very much about the systemic pressures and how pressures vary in the aorta during the day. And clearly, the main problem is that wall properties change from patient to patient and often change as a result of aneurysmal degradation. Similarly, we don't know very much about the safe level of pressure in these patients. So what about pressure in abdominal aortic aneurysms after endovascular aneurysm repair? Some of the early studies demonstrated quite nicely that when one is able to successfully exclude the aneurysm, the pressure falls down precipitously. But in the presence of leaks outside the aortic stent graft, essentially the pressure remains high. So when we're talking about endoleaks, then clearly with type 1 endoleaks, the proximal attachment zone is a problem, and in those endoleaks, the pressure remains high. And probably the best evidence comes from not a randomized controlled trial, but the Eurostar registry, which collected data on over 1,000 patients throughout Europe, and was probably the best publication came in the British Journal of Surgery, which demonstrated that type 1 endoleak was a significant risk factor for subsequent secondary intervention and aneurysm rupture. Treatment of type 1 endoleak has changed over time, and really the mantra is to get the stent graft up as close as you can to the renal arteries. But new devices have evolved. Those have included endostaplers and giant stents to try to reline the proximal stent. Similarly, the Hayes article on the Eurostar registry in BJS was able to demonstrate that type 3 endoleaks, those endoleaks in the middle of aortic stent grafts are a significant risk factor for rupture. These are pretty easy to treat, essentially just to reline the aortic stent graft. What about type 2 endoleaks? The Eurostar registry and other data have really shown that these are mostly benign leaks and very, very rarely cause problems. And essentially these are due to backflow into the inferior mesenteric artery or via the lumbar arteries. If you go back to essentially Peacock's article, we're talking about thrombosing the aneurysm sac. People have used coils to treat type 2 endoleaks, but actually again, aneurysm packing or filling the aneurysm sac with thrombogenic material as in this article in British Journal of Surgery, was not completely dead, and people were using gelatin sponge at this stage to fill the dead space to prevent these leaks coming back into the aneurysm and expanding. But essentially, data existed to suggest that the vast majority of these leaks were already completely benign. I'm talking about type 2 leaks. If you actually look at the data from the Albany group, and their preferred open treatment for aortic aneurysms was actually to bypass the aneurysm. Essentially, they very rarely experience sac expansion due to backfilling, due to effectively type 2 endoleaks or patent inferior mesenteric arteries or patent lumbar arteries. So actually, if we paid any attention to this article, which was produced in 1996, it would have saved a lot of patients from unnecessary secondary interventions, particularly in the EVAR trials. Significant numbers of patients actually had a secondary intervention for a completely benign complication. And what of endotension? Clearly, especially in the days of the first generation stent grafts, a large proportion of patients ended up with an apparently normal appearing aorta with a normal stent graft, but then the aneurysm ruptured. Now, endotension is essentially something which was a phrase which was coined by Jeff White and also by the late Jeff Gilling-Smith to suggest that there was a raised pressure within the aneurysm sac but without direct evidence of an endoleak. Very difficult to measure, of course, and we have measured it indirectly over time with a surrogate marker of aneurysm sac expansion. There have been a number of models, both in glass and in animals. But essentially, we need to learn the same lesson, and that lesson is that thrombus transmits pressure. We had to go through the same lesson learning process for this. So this really raised the issue. How do we survey these patients? The vast majority of costs in aortic aneurysm repair using the endovascular method is in the long-term surveillance, and the vast majority of cost disparity between open repair and endovascular repair. So the holy grail, everyone was hoping that we could have a reasonable measure of intra-sac pressure. But actually, the studies have shown that actually these sort of minimally invasive sac pressure monitoring devices, which can be left behind within the aneurysm sac, have not really borne any fruit at all, because you get compartmentalization within the sac. The pressures within the sac vary from place to place, and suddenly it's not clear what safe pressure levels are. So essentially, these sort of devices, which were held in, well, we all waited for with great anticipation, have really sort of died the death. So really, what is the future of endovascular aneurysm surgery? It's really to try to rationalize surveillance. We need to be able to predict patients who still have a pressurized sac in a reliable fashion. We obviously need to increase the durability, and we need to find devices which are even more simple than the devices are today. Of interest, it may well be that endovascular aneurysm repair is about to undergo another revolution. This is the latest device called the Endoleaks device, which is undergoing CE marking studies at present. And essentially it involves 2 stents being placed up into the aorta below the renal arteries and deployed. And then, surprise, surprise, a polymer is injected into the aneurysm sac to stabilize this. This is a very, very simple procedure. And a final angiogram shows that the essentially contrast flows down the stents, and the polymer sits in the aneurysm sac and fills the great void. So this is your normal aneurysm, your 2 stents with contrast obviously going down there, your blood flowing down there, and the whole thing is supported by the polymer. So we do need to look back, and essentially I think Peacock showed us quite nicely into the future. Thank you.